Hello everyone, welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant in Unacademy. I have an experience of teaching undergraduate and postgraduate medical students. Hi Sumitra, and I have done my MBBS and MD from Rajiv Gandhi of Health Science. Okay, so today we are going to have a discussion on endocrinology. So, a few conditions, obesity and thyroid. So we'll be discussing these. Okay, so there will be it's going to be a short quiz followed by a few discussion topics, which discussion which are very important in terms of endocrinology. We'll have that discussion today. So before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform. There are a lot of benefits you can avail from this platform. Firstly, the daily life classes. So there are various educators in this platform having regular classes. You can attend their class, engage in discussion, ask your doubts, and all these doubts will be answered in the live chat box. Okay. Next, coming to the structured course. So whenever you're preparing for your entrance exam, you need to have a structured approach. You need to plan really well. So by the time you give your entrance exam, you would have revised very well. So here in Unacademy, all our courses are structured in line with your exam syllabus, and this is going to be a huge boost for your preparation. Next, coming to the live tests and quizzes. So whenever you're preparing for your entrance exam, you need to evaluate yourself. You need to know what are your strong areas, what are your weak areas. That is only possible if you attend as many tests and quizzes as possible. So here in Unacademy, there are regular tests and quizzes happening, and it will help you to evaluate yourself better, and also it will give you a detailed analysis of your performance. Okay, fine. Next, coming to the unlimited access. So once you subscribe to the subscription, you get unlimited access to all the classes that are exclusive to the subscription platform. Okay, so yeah, so along with all those special classes which are accessible to everyone, subscription in the subscription there are certain classes which are only accessible to the subscribers, right? So here, once you subscribe, you get access to all those classes, and even if you've missed the live class, you can go back and watch the recorded classes again and again, all this in the comfort of your home, in the comfort of your own device. So I would highly recommend this platform, and platform from the beginning part of your preparation will do a long way. Next, coming to the top educators. So these are the top educators in the platform, and you can attend their classes as well. Next, so all the 19 subjects required for your NEET PG preparation are taught in this platform. And also, if you go to check the Unacademy app, you can see there are various courses like the foundation course, batch course, the crash course. So you can, these are all the compact classes of various subjects. You can go and attend these classes based on your requirement. Okay. Next, coming to the NEET PG subscription package. So as you can see, the NEET PG subscription package varies from 1 month to 2 years, right? So I would highly suggest the 1 year or the 2 year subscription, especially to students who are in their third year, in their final year, or in their internship where they do not have all full day to sit and study, because you have to study your own subjects, plus you have your clinics, you have your internship hospital duties, right? So all that that is why this will be very reasonable and economical. Next, coming to the students who are giving their NEET PG 2021, for them the 6 month subscription should suffice. Okay, the 6 month subscription will cost you 20,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 18,000. And the 1 year subscription is 25,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 22,500. While the 2 year subscription is 30,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 27,000. So you only have to just know, you're just a click away to subscription. Once you subscribe, you get access to all the classes. Okay, fine. So now we'll go to today's topic of discussion. So we are going to have an endocrine quiz. So the first question being, a 9-year-old boy presents with growth retardation, episodes of hypoglycemia. Physical examination reveals that his short stature, micropenis, fat, and high-pitched voice. The skeletal survey of the bone reveals the bone age of 5 years. Which of the following is the most appropriate diagnosis? Is it malabsorption? Is it growth hormone deficiency? Is it adrenal tumor, or is it thyroxine deficiency? So it's a 9-year-old child, has growth retardation, There is hypoglycemia, there is short stature, micropenis. Yes, very good, Sumitra. So the answer is growth hormone deficiency. Yes, very good. So there is growth hormone deficiency. So along with growth hormone deficiency, so if the pituitary is, there are various other hormones also which are affected, which are reduced, and that can cause the above symptoms. Okay, fine. So the next question. Characteristic features of growth hormone deficiency includes all except short stature since birth, symptomatic hypoglycemia, late tooth eruption, or sexual infantilism. Tell me characteristic features of growth hormone deficiency. Yes, very good. So short stature at birth. So growth hormone, even if it doesn't affect in the intrauterine period. This is a hormone which doesn't affect the intrauterine period. So most of the children at birth are normal, and eventually they have the presentation happening. So very good. So especially thyroxine is the one which affects the intrauterine period, but while growth hormone doesn't affect the intrauterine period. So the answer over here is short stature since birth is not a feature of growth hormone deficiency. While the hypoglycemia, delayed tooth eruption, and sexual infantilism, that is basically not attaining the. Yes, very good. Yeah, so they are not sexual infantilism, basically not attaining the sexual secondary characteristics of beyond puberty. Fine. So next question. Weak giants are produced by thyroid adenomas, thyroid carcinomas, parathyroid adenomas, or pituitary adenoma. Weak giants are produced by weak giants. Weak giants are produced by. Yes, very good, Sumitra. So the answer is pituitary adenoma. Okay, okay, fine. Next question. Which is falls in congenital hypopituitarism? Okay, which is falls in congenital hypopituitarism? Yes, Archie is also right. We go to the next question. Growth hormone levels of less than 7 nanogram per ml, hypoglycemia, baby small at birth, or delayed puberty, which is falls in congenital hypopituitarism. There was already a similar question, but so there is congenital hypopituitarism. So what is falls out of this? Very good. So small baby at birth. So generally, even if there is any hypopituitarism, the it won't have an intrauterine effect. So whatever presentation happens, it is after the birth or after 1 year of age. So a child who is born with hypopituitarism will have a normal looking body. Fine. Or fine. Next question. Short stature secondary to growth hormone deficiency is associated with short stature, secondary to growth hormone deficiency, is associated with normal body proportion, low birth weight, normal epiphyseal development, or height age equal to skeletal age. So short stature, which occurs because of growth hormone deficiency, is associated with. So how is the growth in this child? Is a short stature not having normal body proportion? Is it low birth weight, or there is a normal epiphyseal development? Height age is equal to the skeletal age. So what is it? Yes, very good. So the answer is normal body proportion. So in growth hormone deficiency, even if there is short stature, there is no difference in the disproportionate short upper and lower segment. So the upper and lower segment is proportionate. So the short stature secondary to growth hormone deficiency has a normal body proportion. Next, okay, tell me few of the condition. Short stature with abnormal Abnormal body proportions. Yeah, so tell me some of the short statures with abnormal body proportions. First. There are like few questions to talk. So one is Turner syndrome, right? Turner syndrome, yes, very good. Hypothyroidism, achondroplasia, very good. Rickets, right. Mucopolysaccharidosis, very good. So these are the few conditions you have to keep in mind. You know, I have done a class, a YouTube class on short stature. Okay, so I have done a YouTube class on short stature. You should attend those classes. Yes, so if there is any spinal surgery or spinal irradiation also can cause short stature. Okay, fine. Next question. A 7-year-old underwent a neurosurgery for craniopharyngioma, following which pituitary functions were lost. Which of the following hormones should be replaced first? Okay, hydrocortisone, thyroxine, growth hormone, or prolactin. A 7-year-old underwent a neurosurgery for craniopharyngioma. Then all the pituitary functions were lost. Now, which hormone will you replace first? Which hormone will you replace? A lot of questions have come related to this, so tell me. Yes, very good, Sumitra. So, we replace hydrocortisone first. This is very important. Yes, very good, Kirti. So, now if you replace thyroxine before hydrocortisone, I mean before steroids, what will it do? If you replace thyroxine first, thyroxine before steroids, what will happen? What will happen? There will be adrenal crisis. Okay, so the steroids or hydrocortisone is a very important hormone, and that's why it has to be. Though there are a lot of hormones being lost, I mean, or they reducing, you have to replace hydrocortisone first. So you should not replace thyroxine first. So that is very important. Replace hydrocortisone, steroids first. Then is the other hormones. Okay, if you replace thyroxine before steroids, it can lead to adrenal crisis. Remember, next question. Bone age in growth hormone deficiency is delayed, advanced, normal, or initially delayed then normal. Bone age in growth hormone deficiency is delayed, advanced, normal, initially delayed then normal. Yes, very good, Sumitra. The answer is it is delayed. So the in growth hormone deficiency, the bone age is delayed. Fine. Next, which drug should be given first in Sheehan syndrome? Estrogen, cortisone, thyroxine, or growth hormone? Which hormone, which drug is given, or which hormone is given in Sheehan syndrome first? In Sheehan syndrome, what is given? What is Sheehan syndrome? First, you'll tell me the answer and then tell me what is Sheehan syndrome. Okay. So tell me which drug is given first in Sheehan. It's a similar question we have already discussed. It is a similar answer. Yes, very good. So the answer is cortisone. So you will give cortisone. So what is Sheehan syndrome? So what is Sheehan syndrome? So it is not a pediatric topic, but it is related to a pregnant woman. So what is Sheehan syndrome? What is Sheehan syndrome? So Sheehan syndrome is postpartum partum infarction of the pituitary. Okay, infarction of pituitary, which leads to Yes, yes, very good. It's a pituitary apoplexy. Okay, very good. So that leads to hypopituitarism. Very good, very good. So the answer is cortisone here. Yes, very good, very good. Next, all of the following are true about craniopharyngioma except it is derived from rat case pouch, contains epithelial cells, present in cellular or intracellular location, causes visual disturbances. So tell me what is false here? What is false here? All of the following are true except one. What is false? So, is it derived from the rat case pouch, contains epithelial cells, present in cellular or intracellular location, causes visual disturbance. It's about craniopharyngioma. No, 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 that is not the answer. So the answer is okay. I'll give another 10 seconds. So let's see. Yes, yes, you're right. So the answer is present in cellular or intracellular. So the craniopharyngioma is actually in a supracellular location. Okay, so it is located in the supracellular location. So at the end, supracellular location. Okay, so that is wrong over here. So present in cellular intracellular location is wrong. Okay, so the answer is the craniopharyngioma is in a supracellular region and therefore the answer present in cellular or intracellular location to be marked here. Fine. Which of the following statements about galacturia is true? Which of the following statements about galacturia is true? Maybe bilateral associated with lactation, associated with prolactinoma. All of the statements are true. So we are talking about galacturia. So what is galacturia? Flow of milk from the breast. Okay, now tell me. Flow of milk from the breast is galacturia. So which of the following statement is true? So it may be bilateral, associated with lactation, associated with prolactinoma. Yes, very good, Sumitra. So the answer is all of the statements are true. Okay, so all of the statements are true here. Next question. All are causes of hyperprolactinemia except bromocriptine, methyl-dopa, phenothiazine, or and metoclopramide. So all are the causes of hyperprolactinemia except what is not the cause? What is the drug which is not a cause for hyperprolactinemia? Yes, very good, Deepesh. So the answer is bromocriptine. So you should be knowing. So in case of prolactin symptoms, you give bromocriptine as a therapy. Okay. So over here, bromocriptine is the answer. It does not cause hyperprolactinemia. Okay, no confusion. While all these causes hyperprolactinemia, bromocriptine in fact is used as a treatment, fine, to reduce the symptom. Fine. Next question. Which of the following is the most common type of pituitary adenoma? Thyrotropinoma, gonadotropinoma, prolactinoma, or corticotropinoma? Is the most common type of pituitary adenoma. Which is the most common type of pituitary adenoma? Is it thyrotropinoma, gonadotropinoma, prolactinoma, or is it corticotropinoma? Very good, Archie. So the answer is yes, and also Sumitra, the answer is prolactinoma. Okay, it's prolactinoma. That is the most common type of pituitary adenoma. Very good. So next coming to heel pad thickness is increased in which of the following condition? Heel pad thickness is increased in which of the following condition? Is it acromegaly? Is it prolactinoma? Is it Cushing syndrome? Or is it hyperparathyroid? Heel pad thickness. So this is a very important question. So has been asked in AIMS. So now tell me, heel pad thickness is increasing which of the following condition? Very good, Smita, very good. So the answer is acromegaly. Okay. So here I will have a small discussion at the end about all these topics. So acromegaly, the heel pad thickness is increased. Okay. Fine. Next question. Confirmatory investigation for acromegaly is insulin-induced growth hormone suppression, glucose-induced growth hormone suppression, random growth hormone assay, or insulin-like growth factor 1 level. Confirmatory investigation for acromegaly. What is the confirmatory investigation for acromegaly? This is for acromegaly. What is the confirmatory investigation? No. The answer is, so we're talking about acromegaly, the answer is glucose-induced growth hormone suppression. Why is the confusion? Why have all of you answered insulin-like growth factor 1 level? So the answer for acromegaly is, so when does acromegaly happen? When does acromegaly happen? So basically you have to suppress, okay? So you have to suppress the growth hormone by glucose. So glucose-induced growth hormone suppression is done. So that is the investigation of choice for acromegaly. Do not get confused. Fine. The next question. So this is for acromegaly, not a normal growth hormone deficiency. Talking about acromegaly. Okay. Next question. Not a feature of Lawrence Moon Beetle syndrome, retinitis pigmentosa, polydactyly, diabetes insipidus, or mental retardation. So I'll be discussing about this also, about acromegaly again. So now we'll finish up with the questions first. Not a feature of Lawrence Moon Beetle syndrome. Retinitis pigmentosa, polydactyly, diabetes insipidus, mental retardation. This is a very important question. Yes, very good. So the answer is diabetes insipidus. So diabetes insipidus is not a part of Lawrence Boone Middle syndrome. So obesity is another thing. So in my short stature class, I had discussed. So whenever a child who is short, okay, who is short and whose weight is also decreased, then the chance of it being constitutional or a familial or a familial cause of short stature is high. But if a child is short and if the child is obese, then you have to always think about certain endocrine conditions or genetic disorders. Especially genetic disorders, it is Lawrence Moon Beetle syndrome you have to keep in mind. Endocrine causes like Cushing's syndrome you have to keep in mind. So these are, so generally obesity and short stature do not go hand in hand. So generally children who are obese, they are quite tall. Okay, so if they are short, they're not growing well, then it should be an endocrine or a genetic disorder. Fine. Next question. All are causes of obesity except growth hormone deficiency, Prader-Willi, Turner syndrome, hyperthyroidism. The very simple answer. There shouldn't be any doubt here. All are causes of obesity except. Actually, this class was, endocrine questions I had bought for discussion is because Aparna had asked. Aparna is only not there in today's class. I mean, I got late, I know. She would. Anyway, all are causes of obesity except growth hormone deficiency, Prader-Willi, Turner syndrome, hyperthyroidism. Very good. So the answer is hyperthyroidism. So it's a very simple answer. So basically what happens sometimes you all will see But instead of reading it as hyper, you all might read it as hypo. So always read the question nicely, well, because there are chances you all will. Sometimes what happens is in your head it will be always that the questions will be complicated. No, the questions will be always simple. You have to just put your head over there. Okay, the questions will be simple. Not complicate the questions in your mind. Okay, this is one of the best examples. Again, this was a question from AIMS that too. Fine. Not a manifestation of insulinoma, a rare neuroendocrine tumor. Diplopia, blurred vision, altered mental status, sweating, palpitation, weight loss, anxiety. So now tell me, not a manifestation of insulinoma. Insulinoma. Not a manifestation of insulinoma. Diplopia, blurred vision, altered mental status, sweating, palpitations, weight loss, anxiety. Very good, Deepesh. So the answer is weight loss. So weight loss is not a part of insulinoma. It is weight loss. Okay. Next. Genetic syndromes manifesting in children with obesity as one of the features. Okay, like I'm talking about Archie. I didn't get. Okay, fine. Genetic syndromes which are associated with obesity. Okay, tell me, is it Carpenter syndrome, Cohen syndrome, Prader-Willi syndrome, or all of the above? Yes, very good. So the answer is all of the above. Yeah, so basic, all of them. Which endocrine disorder is associated with epiphyseal dysgenesis? Hypothyroidism, Cushing syndrome, Addison's, or hypoparathyroidism? Which of the endocrine tumor is associated with epiphyseal dysgenesis? Remember this. Epiphyseal dysgenesis. It's a very simple question. You can answer this. Which endocrine disorder is associated with epiphyseal dysgenesis? Yes, the answer is hypothyroidism. So out of all these, okay, hypothyroidism, short stature is a feature of hypothyroidism. And we are talking about epiphyseal dysgenesis. So that leads to short stature. So right, that is why you have to be able to correlate. And the answer is hypothyroidism. Very good. Next, most common cause of congenital hypothyroidism. Okay, again, this is a very, very important question. A lot of questions have come in the past. So, is it deficiency of deoxymanase? Deoxymanase, I've written deoxymanase, defective release of thyroxine, thyroid dysgenesis, or Pendred syndrome. Okay, okay. Okay, most common cause. Yeah, I've got a throat pain. Yeah, I'm talking loudly. I've got a very bad throat pain. Now, most common cause of congenital hypothyroidism: deficiency of deoxyminase, defective release, thyroid dysgenesis, or Pendred syndrome. Yes, Sumitra and Deepesh are right. So the answer is thyroid dysgenesis. Is very, very important cause of hypothyroidism in children. Okay. So can you hear my voice now? So tell me if you can hear my voice. I got a very, screaming. My voice is gone a little bit. So tell me what, can you hear my voice? Just give me a thumbs up if you're able to hear my voice. Are you able to hear my voice? Okay, fine. So the most common cause, so this is a very important question, okay, have been in pediatrics. So for congenital hypothyroidism, the most common is thyroid dysgenesis. Okay, fine. Next, not a feature of hyperthyroidism is short metacarpals in hands, delayed puberty, delayed bone age, or altered upper and lower segment ratio. Okay, not a feature of hypothyroidism. Short metacarpals in hand, delayed puberty, delayed bone age. Okay, so once okay, we finish this. Delayed bone age and altered upper and lower segment. Yes, very good, Sumitra. So the answer is short metacarpals in hand. So that is not seen. So rest delayed puberty is there, delayed bone age is there, the upper and lower segment ratio is altered. Very good. So now I forgot to discuss this. Tell me what is Pendred syndrome? Tell me what is Pendred syndrome? What are the components of Pendred syndrome? This also is a question they might ask you. So just let me tell me what is the what are the so what are the components? So basically there is severe hearing loss. So sensory neural hearing loss. Okay, there is sensory neural hearing loss. Yes, very good, Sumitra. Plus a goiter. This goiter could be hypo or euthyroid. Okay, so remember this is very important. So Pendred syndrome, the sensory hearing loss with a goiter. Okay. Yes, very good, Sumitra. Okay, fine. Next question. 8-year-old child presents with lethargy, multiple epiphyseal breaks, Vermean bones with growth retardation and mental retardation. Diagnosis is rickets, hypothyroidism, scurvy, hypoparathyroidism. This is an 8-year-old child who has lethargy, multiple epiphyseal breaks, Vermean bones, and mental retardation. Very simple question. So you'll be able to answer this. Yes, very good. So hypothyroidism. What is Vermean bones? Do you all know what is Vermean bones? What is Vermean bones? Yeah, so I'll have answers. So tell me what is Vermean bones? So basically in the bones which are joined by sutures. Okay, so sutural joints like in the brain, in the skull. So there are certain bones which are adjoining this, which is not seen. So the bones, the bones there are the bony structures adjoining these two bones with the small bones in the suture. So very good. So you were able to tell it better. So small bones. So if this is the suture, so in between that there are certain bones are joining the two sutural bones. So small bones in the suture. Okay, that is the Vermean bones. Fine. Next. Which of the following are true regarding cretinism? Short limb compared to trunk, proportionate shortening, short limbs and short stature, short limbs and long stature. So what is true? What is true? In cretinism. So cretinism in hypothyroidism. So tell me, which of the following are true regarding? Okay, so short stature, yes. So sometimes if there's not short stature on, so you should remember this. Short limbs compared to trunk. So this is also there. This is there. But if some child doesn't present with short stature. There is the height might be disproportionate. So you compare this short limb compared to the trunk. That is the answer. Okay, not necessarily sometimes all hypothyroid, mild hypothyroidism might be there, but there will be a disproportionate in the body segment. Okay, so that is very important. Next, the feature of neonatal hyperthyroidism is all except we're talking about hyperthyroidism. Okay, so one triangular faces with craniosynostosis, congestive heart failure, advanced osseous maturation, or goiter is rare. So we all are features of neonatal hyperthyroidism except triangular faces with craniosynostosis, congestive heart failure, advanced osseous maturation, and goiter is rare. We're talking about hyperthyroidism, neonatal hyperthyroidism. Okay, so the answer is goiter is rare. Okay, so they will have a swelling. Okay, so they have a triangular faces. So check the pictures of neonatal hyperthyroidism, you'll have a clue. Okay, so the answer is goiter is rare. Fine. Which of the following drug causes hypothyroidism? Amiodarone, lithium, interferon alpha, or all of the above? Which of the following causes hypothyroid? So now tell me these drugs which causes hypothyroid. Amiodarone, lithium, interferon alpha, or all of the above? Okay, tell me these all. Yes, very good, Sumitra. So the answer is all of the above. All these drugs cause hyperthyroidism. Fine. Okay. So now we have done for the questions today. So I have kept a very short quiz today. Okay. So now we'll have a small discussion on the various topics. So first I'll start with hypopituitarism. If time permits, I'll discuss all or else only hypopituitarism. Okay. So hypopituitarism. Okay, so what is the first hormone? So if there is hypopituitarism, tell me what is the first hormone to decrease? What is the first hormone to decrease? So you all are going to tell me the answer and then I write first hormone decrease if there is hypopituitarism. What is the first hormone to decrease? It is the growth hormone. Okay, it is the growth hormone. And what is the last hormone to decrease? What is the last hormone to decrease? Yes, very good, Hoshiar. What is the last hormone to decrease? The last hormone to decrease is ACTH. Okay, ACTH. Now this hypopituitarism can occur in levels. Okay, hypopituitarism can occur in three levels. One is the hypothalamus, thalamus. See how it is growth hormone, then comes FSH, LH, then comes prolactin, and then comes ACTH. Okay, they are fine. Now I'll tell you. So hypopituitarism can occur in three levels. One is the hypothalamus, one is the pituitary stalk and one is the pituitary itself. Okay, so the hypothalamus, what are the causes which affect go to hypopituitarism in at the level of hypothalamus? So at the level of hypothalamus, one important cause is the Kalman syndrome. Do you know what is Kalman syndrome? So Kalman syndrome has it's a hypogonadotropic hypogonadism. So over here there is delayed puberty, delayed or absent puberty, and there is impaired sense of smell. Okay, there is impaired sense of smell. So, okay, one hypothalamus cause is the Kalman syndrome. So, next, there are certain tumors in the hypothalamus. Tumors, infection like meningitis, okay, or tuberculosis, which affects the hypothalamus, or ischemia of the hypothalamus. So, these are the conditions that can lead to hypopituitarism. Fine. So this is the first level. So various levels where the hypopituitary can occur. One is the hypothalamus. Next is the pituitary stalk. Then third is the pituitary itself. Yes, very good. Next, coming to the pituitary stalk. So for the pituitary stalk, what can happen? So very important. There is one very important, the most common intracranial tumor in pediatrics. So what is that? The most common intracranial tumor of pediatrics that comes in this area. So that is the craniopharyngioma. Craniopharyngioma. Okay, there could be some trauma or a meningioma. Fine. So in the pituitary, so what are the causes affecting the, yes, very good, Sumitra. So the most common intracranial tumor in pediatrics is craniopharyngioma, that you have to keep. Next, the pituitary. What are the pituitary causes lead to hypopituitary? What are the pituitary causes? So there could be trauma, there could be irradiation, there could be inflammation, okay, there could be infiltration, and now comes the Sheehan syndrome, what Hosha said. So the pituitary is the one which is affected, not the hypothalamus, but the Sheehan syndrome. So hemorrhage occurs in the pituitary. Okay, so remember that Sheehan is not the hypothalamus, it is the pituitary. Fine. So pituitary. Next. Fine. So now there are now the features of hypopituitarism. The features of hypopituitarism is either because of the hormones or because of the mass effect of the tumor. Okay. So now there are various hormones which reduces. One you all know is the growth hormone deficiency. Growth hormone deficiency. Next, if there is gonadotropin deficiency, what will happen? The child can have amenorrhea, or there could be oligomenorrhea. So there could be gonadotropin deficiency leading to amenorrhea or oligomenorrhea. Fine. Next, there will be thyroid which will be affected. Thyroxine deficiency, hypothyroid, thyroid deficiency, thyroxine deficiency. So that will lead to hypothyroid feature. Next, corticotropin will be affected, ACTH will be decreased, then there will be prolactin. So all this you know. What are the mass effect? What happens in these children? So the mass effect includes there will be headache. Okay, there is bitemporal hemianopia. So when does this happen? Tell me, when does bitemporal hemianopia happen? So I will tell you all, but you will tell me bitemporal hemianopia. When does that happen? Bitemporal hemianopia. So bitemporal hemianopia happens when the tumor presses on the optic chiasma. So that is the Mars effect. Okay, when the tumor or there's a Mars effect on the optic chiasma. Yes, it happens in craniopharyngioma, but that happens because tumor presses on the optic chiasma. Fine. So that is a very important thing. So now we know what is Sheehan syndrome and we know what is the first hormone to be replaced in case of hypopituitarism. So that is the steroids. So steroids or the hydrocortisone should be replaced first, not the thyroxine. So thyroxine, if you replace before the steroids, it will lead to adrenal crisis. Okay, remember this, it will lead to adrenal crisis. Okay. So another thing is the pituitary tumor is divided into micro and macro. Microadenomas and macroadenomas. Okay. So if the tumor size is less than 1 centimeter, it is micro. And if the tumor size is more than 1 centimeter, it is macro. Okay. Much you have to keep in mind. So I've already told you what are the pressure effects. So okay. So what are the treatments? So one is hormone therapy. So another thing is, as a pressure effect, these patients can have diabetes insipidus if the hypothalamus is involved. So if the hypothalamus is involved, only then the diabetes insipidus. Otherwise, you should not be telling hypopituitarism, there will be diabetes insipidus. So if the hypothalamus is involved, then there is diabetes insipidus. Okay? Yeah. So the treatment includes hormone replacement. Okay, surgery and radiotherapy. So this is the treatment for pituitary tumor. So now we'll come to craniopharyngioma. So we'll do a quick fast craniopharyngioma thing. So craniopharyngioma. Okay, so in craniopharyngioma what happens? So there is no secretion of any hormone and there is a bimodal age of presentation. So one is it's the childhood and then it is over 60. So remember there is bimodal age of presentation. So one is at childhood, then the other is beyond 60 years. You should remember that. Yeah. Tell me, Dayal, what is your question? Yeah, what is your doubt, Dayal? So this craniopharyngioma is the commonest intracranial tumor in pediatrics. So commonest intracranial, okay, in pediatrics. Okay, and this is one of the commonest cause of hypopituitarism in children. Commonest cause of hypopituitarism in children. Okay, next what you should know, how is it formed? Tell me, how is the craniopharyngioma derived? Tell me this, you all know. I want you to tell so that you all will be able to remember. That is why I'm asking you a question. It's not like, I can just tell and go. If you all are answering over here, you all will remember better. So why does craniopharyngioma happen? I didn't understand. I'm not understanding what you're saying. Tell me, what anything different from medicine? What do you want? Okay, so this is derived from the remnants of rat case pouch. Okay, derived from rat case pouch remnants. Okay, and this is it is in the supracellar. So always remember the site is the supracellar. Supracellular. Yes, very good. Yes, there is calcification. Okay, this tumor has there is hemorrhage and calcification. Very good. There is calcification. Okay, so the tests are CT and MRI that will show calcification, and treatment is surgery with or without radiation, post-op radiation. Yeah, so this much you should keep in mind. If the hypothalamus is involved, so what happens? This tumor will erode and can affect damage the pituitary stalk, okay, and that and also it can affect the hypothalamus. So if it affects the hypothalamus, these patients can have diabetes insipidus. Okay, next, now we go to hyperprolactinemia. Hyperprolactinemia. So what are the causes? So how does hyperprolactinemia occur? There are two major causes. So tell me, how does hyperprolactinemia occur? How does hyperprolactinemia occur? So one is prolactinoma, prolactinoma. Okay. So this prolactinoma is the most common hyperfunctioning pituitary adenoma. Okay. This is the hyperfunctioning pituitary adenoma. Adenoma. Okay. That is prolactinoma. Yes. Then what are the other causes? So tell me the drugs which cause. So what are the drugs? So basically the dopamine antagonists. Okay, the dopamine antagonists are the drugs which cause hyperprolactinemia. So dopamine antagonists. Okay, so we were talking about methyl dopa and all, right? So the drugs which have the antagonist effect. Okay. Next, what are, so one is that. So physiologically, in which condition there is hyperprolactinemia? Physiological condition. So that is, one is pregnancy. There could be stress, right? Right? So this is it. So sometimes if the, yeah, another thing is when the pituitary stalk is cut, pituitary stalk is affected, okay, is damaged, is cut. So especially during a surgery, or if there is trauma, or if there is a craniopharyngioma which affects the, which erodes and affects the pituitary stalk. So that time also there is hyperprolactinemia. Very good. So these are the various features. So how do you test? What are the investigations? What are the investigations for hyperprolactinemia? So you get a serum prolactin level. Okay, so you get a serum prolactin level. So when you get a serum prolactin level, if it is more than 100 micrograms per ml, then it is suggestive of macroadenoma. But if it is more than 200 micrograms per ml, it is suggestive of prolactinoma. Okay. So more than 100 is macroadenoma, but if it is more than 200, it is prolactinoma. One, yes. Then it's the CT. So in the CT, what will you do? You'll have to check CT or MRI is done. So over here you see the size. So if the size is less than 10 mm of an MRI, then it is microprolactinoma. Okay. If it is more than 10 mm, it is macroprolactinoma. Okay. Fine. So what are the treatment? What is the treatment for hyperprolactinemia? What is the treatment? Two important drugs you should remember. Okay, one is bromocriptine. It is a dopamine agonist. Okay, bromocriptine, and the other is another dopamine agonist which is very useful is the cabergoline. Okay, cabergoline is used. So these are the drugs which help in decreasing the secretion of prolactin. So bromocriptine and cabergoline is used. Surgery is also done if there is a tumor. Next, if radiation therapy, if the tumor or the macroadenoma is not resectable, then you go for radiation therapy. Okay, so this is you have to know. These are the this is about hyperprolactinemia. Next, we'll talk about acromegaly. Okay, tell me about acromegaly. What is acromegaly? So basically, what happens? This is because of a pituitary adenoma which releases growth hormone. There is a pituitary edema that is releasing growth hormone, secreting growth hormone. If this occurs before the epiphyseal closure, so if this pituitary, if this pituitary adenoma releasing growth hormone occurs before the epiphyseal closure, this gigantism. And if it occurs after epiphyseal closure, it will lead to acromegaly. Okay, it will lead to acromegaly. So how will they present? So how are these patients? Yeah. Hi Abhay. So how do they present an acromegaly? So this is the last topic for today. So once acromegaly is done, we are done. So tell me, so these children will have excessive growth of the hands and the feet. So we've discussed in the question previously, the heel thickness is seen in acromegaly, right? So there is excessive growth of hands and feet. What else we see? Jaw prognatism is there. Voice deepening is there. Okay, there can be joint erosions. Carpal tunnel syndrome. So remember, carpal tunnel syndrome is there. Okay, proximal muscle weakness is there. So these things you should need to know. Acromegaly, there have been questions. So remember, there is a pituitary adenoma, which causes growth hormone secretion. Okay, and if this growth hormone secretion occurs, yes, very good, Deepesh. So if this growth hormone occurs before the epiphyseal closure, it is gigantism, and if it occurs after epiphyseal closure, it is acromegaly, and it can present. These patients can present with excessive growth of hands and feet. There is a prognatism. Remember, very important, voice deepening, joint erosions, and the carpal tunnel syndrome and proximal muscle weakness. So these are very important. And what are the complications in a child with acromegaly? So what are the complications? What can happen? So um, these children can go for diabetes mellitus. Okay, so they can go for diabetes mellitus. Okay, so they can have hypertension. They can have cardiomyopathy. Okay, there is the increased chance of developing colon cancer. Okay, increased chance of developing colon cancer. So remember, these are the complications in a child with acromegaly. So what is the screening test? So we have discussed in our quiz. So what is the screening test? What is the screening test? What is the screening test in acromegaly? So there will be an increased heel pad thickness. So when you get an X-ray of the lateral view of the heel, you see increased heel pad thickness. Increased heel pad thickness on X-ray lateral view of the heel. So tell me, what is the most common cause of? Yeah, IGF. Yeah, insulin-like growth factor. One is increased, but I have told you the glucose. Yes, the glucose induced growth hormone suppression is the investigation, the best investigation. So glucose induced growth hormone suppression. Okay, so that is the most definite investigation for acromegaly. Yes, insulin like growth factor 1 is increased, but another important thing is there is increased heel pad thickness on an X-ray lateral view of the heel. So tell me the most common cause of increased heel pad thickness. The most common cause of increased heel pad thickness is heel injury. Okay, so don't confuse. Then confirmation by MRI, CT, check for the neoplasm. Okay, so what are the treatment drugs which are used for treatment? So somatostatin analogs are used. Somatostatin analogs, that is the octreotide. So octreotide is used. Dopamine agonists are used. So tell me, what are the dopamine agonists? We have already discussed. What are the dopamine agonists? We use bromocriptine and cabergoline. Okay. Then we use the growth hormone receptor antagonist. Okay. Surgery is done. Surgery is the treatment of choice. Okay. Surgery is the treatment of choice, and radiotherapy is given. Okay, so this is the various modes of therapy, and this is about acromegaly. So we are done. So today we have discussed all this. So yeah, so basically hypopituitarism has been covered. So tomorrow I'll come with another 1 hour class. Okay, so yeah, we'll have a discussion either on endocrinology or a random pediatric quiz. So let's see. Okay, so and in the special class I am having a pediatric quiz. I will I'll publish the class beforehand. I don't know when I'll be presenting, but I will put up. Yes, very good. The growth hormone receptor antagonist is pegvisomant. Very good. So very, very good. Okay, it's the pegvisomant. Very good. Okay, so these are the classes. There is only one pediatric quiz which I'll be taking on special class in the Unacademy app, and over here I have one more class this month. So then we'll be done for this month. So let's see. Okay, so very important. Use my code Shilpa10 to get a 10% discount on the subscription. As I always say, study daily, avoid social media, wake up early, sleep early, and wake up early. And if you have a study partner, them daily and make very crisp notes. Okay, that's very important for you to revise, and at least once in give grand tests, so that will help you to know, help you to manage time, and also will help you to what else to study. Okay, so this is very important. And thank you, Deepesh, Sumitra, for coming today. I missed Aparna actually attends all my classes, so today my timings got missed, so she wouldn't have attended. Anyway, all the best, study well, take care of yourself.